At the beginning of my talk, I would like to thank the APOS give me this great honor to give this APOC Oration. And in this presentation, I would like to share my cases and our recent studies on how we control the growth direction of the mandible in class 3 growing patients. No matter what kind of maxillary orthopedic protraction that you are applying to treat your class 3 growing patients, the question will be the result of any maxillary orthopedic protraction will be compromised by the after protraction mandibular growth throughout the entire puberty. Let me give you this example. This is a 12.5 years old girl whose chief complaint was, I have underbites and my chin is long, and I have been told that I might need jaw surgery in the future, but I don't want to have jaw surgery. So when you look at her face, the extraoral photos, you can see her paranasal depression, which means the maxillary hypoplasia, and you can see the excessive chin throat length, which indicates she got a mandibular prognathodon, and also you can see her facial symmetry, the chin deviate to the left side, and also she got mentality strains and inadequate upper incisor shown and flat smile arc. Intraorally, what we have seen here was she got a class 3 molar relationship, and also she got an anterior crossbite and maxillary severe endocardium, and with number 13 and 23 labial breakouts, and also she got a lower moderate endocardium. So for the treatment planning that we gave to her was to have the expansion for the endocardium, and also we're gonna do Alt-RAMEC maxillary orthopedic protraction for her maxillary hypoplasia, and also we're going to remove the lower 34 and 44 to relieve the lower endocardium and to retract the lower anterior teeth for compensating the future mandible growth during the treatment. But we don't have any planning for her mandibular asymmetry. Here the picture show you she got a double hinge expander set and ready for a 7 weeks of Alt-RAMEC. After 7 weeks of Alt-RAMEC, we started the protocol of intraoral maxillary protraction, and so she got a pair of intraoral protraction spring for 3 months of maxillary protraction. After 3 months of the maxillary protraction, we remove the protraction springs and keep the expander for another 3 months, and then we started to do the orthodontic alignment and leveling. This was the picture in comparison for the pre-treatment and after 3 months of maxillary protraction. You can see her paranasal depression got improved, and also the chin throat length remained and the chin deviation remained as well, because we only protract the maxilla. And a month after the protraction, we started to alignment and leveling the upper and lower dentition, and also ready for the remove of the 34 and 44. And this was 6 months after the protraction. We keep on upper alignment and leveling, and also we were doing the lower space closure. But at this moment, you can see her overbites and overjet were becoming shallow. And that tells us that it's a sign of relapse of the maxilla after the protraction, and also there was a growing of mandible. So we spent like 2 years and 4 months in dealing with and fixing her bites due to the relapse of the maxillary orthopedic protraction and the mandibular growth. And 3 years after the treatment, when she was 15.5 years old, we were able to remove the braces, and still you can see her lower dental midline off to the left side for 1 millimeter, although she got a good buccal occlusion and overbites and overjets. So that is a comparison of her facial profile before the treatment and 3 years after the treatment. You can see the mandibular asymmetry remained, and her paranasal depression improved, chin throat length remained, but chin projection actually got worse after the lower anterior teeth retraction, and also the upper incisor shown and smile arc will also improve as well. So in superimposition of her before and after treatment combing CT, you can see her mandible actually grew 5 mm forward and 7 mm downward at the Pogonian. And actually, if I would not remove the number 34 and 44 because the 5 mm forward growth of the mandible, I don't think I will be able to finish this case in a good buccal occlusion. And for the maxilla, we can see we grew the maxilla forward for 5 mm at the anterior nasal spine, and also she got a 3 mm of maxillary posterior alveolar high development. For the superimposed on the mandible, you can see her contact actually grew for 13 mm. That was quite a lot. And also we had a 5 mm of mandibular posterior alveolar high development. So in this case, you can see after the maxillary protraction, the growth of the mandible could be really a problem for us to treat this kind of class 3 growing patients. So in addition to the maxillary relapse, to control the mandibular growth could be the major determining factor for any class 3 maxillary orthopedics in class 3 growing patients. So how we can control the growth of the mandible? We have two thoughts. First one is to control the growth amount of the mandible, such as the chin cap that I have been using before. But anyway, the chin cap have been proved to be questioned. The effect of chin cap have been proved to be questionable. The second thought will be to control the growth direction of mandible. How is that possible? So I'm going to share with one of our pilot study that we published in 2018 in the APOC trend in orthodontics. And in this study, we using vertical occlusal changes, that is the total arch extruding, have been proposed for improving facial profile without maxillary orthopedics in class 3 growing patients. In this patient, we compared two techniques for the total arch extrusion in order to improve the facial profile in growing class 3 patients. The first one was a bimaxillary total arch extrusion for mandibular clockwise rotation so that the profile can be improved. In this technique, what we used was a bi-razor on the maxillary second molars, and also we applied vertical intermaxillary elastic to bring the upper and lower teeth together while the patient have the bi-razor on the upper second molars. And after have the occlusal contact at all of the front teeth before the second molar, then the bi-razor on the maxillary second molar was removed and have the vertical elastic to bring the second molars to have occlusion eventually. So this is the one of the examples showing you how we use the bi-razor on the maxillary second molar in applying the intermaxillary vertical elastic. Usually when we raise the bites, we always keep the bite opening 1 to 2 millimeter at the anterior teeth. So another technique would be we use the maxillary total arch extrusion for mandibular clockwise rotation so that the profile can be improved. So in this technique, very similar to the technique one, but we put the lower teeth in order to apply the intermaxillary vertical elastic between the upper teeth and the lower teeth. So that is the example showing you how the technique 2 using the lower teeth and the intermaxillary elastic and the bi-razor to extrude the upper dentition. So here are the results. The results showing that the bimaxillary total arch extrusion actually was more effective in improving the facial profile than the maxillary total arch extrusion by downward and backward rotation of the mandible. And here is one of the examples in the study showing that when the bimaxillary total arch extrusion was applied to rotate the mandible downward and forward, and the facial profile was improved in these patients. And this is the example showing you if you're only extruding the upper maxillary dentitions, you are not actually able to improve the facial profile because the mandible still grew forward. So the question will be, can we apply the bimaxillary total arch extrusion for controlling the mandibular growth direction with the maxillary orthopedic protraction? So therefore, I have a case to show you how we apply this technique. We have a 14.3 years old girl whose chief complaint was, I have underbites and my chin is too long. When you look at her face, you can see she got slightly paranasal depressions and excessive chin throat length, chin deviate to her left, and also she got excessive lower incisor shown without upper smile arc. So the CT scan also showing that the mandible deviate to her left side. Also she got a maxillary hypoplasia and mandibular prognathism. Intraorally, you can see she got class 3 malocclusion with anterior crossbite and maxillary anterior crowding with number 13 labia breakout and number 25 missing, and the upper dental midline deviate to her right side. So our treatment plan for her, we will have the Alt-RAMEC maxillary orthopedic protraction to protract the maxilla, and also we will use the bimaxillary total arch extrusion to redirect her mandibular growth direction. So here now she got a double hinge expander set in her mouth, and then we started the program of 7 weeks of the Alt-RAMEC, and here showing you a week after the expansion. Then we bonded the lower dentition and used the lower lingual holding arch and putting on the intraoral protection spring to protract her maxilla forward. This is after 3 months of the maxilla protraction, and the ovobites and the ovoture having improved. So we removed the maxillary orthopedic protraction spring. And the profile before and after the maxillary protraction, here you can see her paranasal depression was improved, and also the lip posture was improved as well, but not for the chin throat length. So a month after maxillary protraction, we started to redirect her mandibular growth direction with the birazors and anterior vertical elastic so that we can rotate the mandible downward and backwards. So that was after 13 months of redirecting her mandibular growth, and at this moment we would like to check whether she got a lip incompetence, since we are rotating the maxillomandibular complex clockwise, and also we would like to check whether she got gummy smile because we were extruding her upper dentition, and also check whether her smile arc and dental profile were well improved. So at this moment, we decided to remove the birazor, stop the vertical elastic at the front, and applied a intermaxillary vertical elastic at the second molar so that we can bring the second molar together for a final detailing of her treatment. So that was a picture showing you how her occlusion was after the treatment, and we have the lingual bonding retainer and access retainer for the maintenance. So comparison of the before treatment and after treatment facial profile, you can see her paranasal depression and the posture were improved. The chin throat length actually decreased, and the smart arc and upper incisor shown were also improved after the treatment. So the superimposition of the compensity showing her soft tissue profile improvement, the paranasal depression and the posture were improved, the chin throat length decreased, and the chin projection reduced as well. The superimpose of the cranial base to show the mandible actually was redirected to grow 2 millimeter backwards and 7 millimeter downwards. For the superimposed on the maxilla, we can show the maxilla was directed to grow forward for 3 millimeter, and also we developed 5 millimeter of the maxillary posterior dentoalveolar height by the total arch extrusion of the maxilla. And when we superimpose on the mandible, we're showing that she got a 3 to 4 millimeter of contact growth, and also she got a mandibular posterior dentoalveolar height development for 2 millimeter. So here, let's put everything together. Was the overall, that means the maxilla and the mandible posterior dentoalveolar height developments was 7 millimeter, and that 7 millimeter actually was bigger and greater than the amount of the contact growth, which was 4 millimeter. And we suppose the dentoalveolar height development at the posterior actually rotate the mandible downward and backwards. So actually, when we look back, when we throw back to look at our previous study, actually from here, although we did not observe this, but actually when you look at the amount of the upper molar extrusion, the amount of the lower molar extrusion, actually the bimaxillary posterior alveolar height growth was around 5.79 millimeter, which was bigger than the contact growth 2.47 millimeter. And so that was the reason why the mandible grew backwards for 1.6 millimeter. So that is an example to showing you our first case, actually showing you this patient, she got a 30 millimeter contact growth, which was bigger and greater than the overall mandibular dentoalveolar height development, which was 8 millimeter. So that the mandible actually grew forward and downward for 5 and 7 millimeter. So therefore, we perform another cohort study to look at how we can control the mandibular growth direction in class 3 maxillary orthopedic protraction patients by total arch extrusion. So the design of the study was a retrospective cohort study. We got two groups of patients. One is a control group who had the maxillary orthopedic protraction. Another one is the total arch extrusion group who had the maxillary orthopedic protraction plus the bimaxillary orthopedic total arch extrusion. So we compare the anterior posterior and posterior change of the mandible, and also we compare the skeleton facial convex and how much we have the posterior alveolar height development and the contact growth. And also we were trying to find the condition for redirecting mandible growth to grow backward and downward if that is possible. So that is our inclusion criteria and exclusion criteria for our sample selection. And our sample size estimation was done by power analysis. We got a pilot study, and we have 5 cases of control group and another 5 cases from the total arch extrusion group. And we had a variable of the horizontal changes at Pagonian, and also we had the FMA and also facial convexity were used as the variable for this pilot study to estimate the sample size. The sample size required was estimated to be 6 patients for the horizontal changes, 9 patients for the FMA changes, and 14 patients for the facial convexity changes in each group under a statistic power of 95% and alpha equal to 0.05. So therefore, we decided to have 14 patients in the control group and 14 patients in the total arch extrusion group. So we have the measurement to see the vertical changes at the anterior nasal spine and the menton. We also have the measurement for the horizontal changes of the anterior nasal spine, 8 points, and the Pagonian. We have an angular measurement for FMA, for SNA, for SMB, for SM Pogonian, for MB angle, for y-axis, and for the facial convexity. We also superimpose to see how much the maxillary posterior and anterior dentoalveolar height development with the FH plane as the reference. And also we measure how much the mandibular dentition been extruded and how much the mandibular posterior and anterior dentoalveolar height development. So we also have the measurement for the T2 to T1 condyle growth in terms of horizontal growth, vertical growth, and the linear growth of the condyle. The readability of the study showing the ICC range from 0.91 to 0.99, and the linear measurements range from 0.07 to 0.017 millimeter, and the angular measurements range from 0.07 to 0.27 degree. The results showing that there was no significant difference between the group at T1 in terms of the number of female and male, the age of the patient at T1, the angle of SNA, SNB, SN Pogonian, MB angle, FMA, YSS, and facial convexity. They were all not significant difference between the groups. And the results showing that in terms of the maxillary growth, there was no significant difference between the control group and the total arch extrusion group. And also the condyle growth also were similar between the group. So that means between the group there has no difference at T1, and the growth amount of the maxilla and the condyles they were all similar between the groups. So our result further showing that the total arch extrusion group had significantly better improvements in SM Pogonian and in facial convexity, in y-axis, and also a shorter treatment duration than the control group. We also showing that the total arch extrusion group had significantly more overall dentoalveolar height developments and more mandibular posture improvement than the control group. And this is one of the most important results of our study. The study showing that the correlation analysis revealed that the mandibular growth, the mandible will grow forward and downward when the amount of the overall dentoalveolar height development was less than the condyle growth. And this is a example that I showed you earlier, showing that the patient had 30 millimeter of condyle growth, and the overall dentoalveolar height development was 8 millimeter, so that her mandible grew forward 5 millimeter and downward 7 millimeter. And the correlation analysis also revealed the mandible grew backward and downward when the amount of the overall dentoalveolar height development exceeded the mandibular condyle growth. And this is the example that I just showed you. The posterior dentoalveolar height development was 7 millimeter, which was more than 4 millimeter of condyle growth, so that her mandible actually grew downward and backwards in this case. And in the middle, we can see that the correlation analysis also revealed the mandible grew downward only when the amount of the overall dentoalveolar height development equal to the condyle growth. So I'm going to show you an example to show you how the mandible can be controlled to grow directly downwards without forward movement. So we got a 14-year-old girl whose chief complaint was that I have underbites and my chin is long. So extraorally, you can see her face had a paranasal depression, which means maxillary hypoplasia, and she got excessive chin throat length, and she got a left side up deep can, and also chin deviated to her left side. Intraorally, you can see she got class 3 male occlusion with anterior crossbite and mild anterochlorine, and also she got a left side up mandibular occlusal cant. The CT scan showing she got a maxillary hypoplasia and mandibular prognathism, and also facial symmetry. Her mandible deviated to the left side. Our planning for her was to orthopedically protract the maxilla by Alt-RAMEC and intraoral protraction spring. And also after that, we would like to redirect the mandible growth direction to be downward and hopefully backwards. So this was after 3 months of the protraction. We remove the protraction spring and keep on anterior vertical elastics. And the comparison of her facial profile before treatment and after protraction. You can see her paranasal depression improved and the chin throat length also decreased slightly. Intraorally, you can see amongst after the protraction, we started the protocol of a downward and backward rotation of the mandible. We put the birazor on the maxillary first molar, and also at the same time we apply the intermaxillary vertical elastic to bring the upper and lower entities to occlude together. And 7 months after the applying of birazor and intermaxillary elastic, we also put the upper teeth in order to help to extrude the upper dentition and develop the maxillary dentoalveolar height. This was after 7 months of the extruding, and then now we switch the 27 bi razor to bi slope. You can see clearly we create a slope on the bi block, and at the same time so that we can shift the mandible to her right side in order to improve her facial symmetry, and at the same time we were applying the intermaxillary elastics. So that was after a year of the bi-slope. You can see the lower dental midline was almost on and was improved. And that was when she was 16.5 years old. We were able to finish her, and she got a good overbite, overjet, and good buccal occlusion as well. Comparison of the facial profile before the treatment and after the treatment. You can see her lip cant and chin deviation were both improved, and also her paranasal depression and the smile arc were also improved as well. And superimposed of the scomping CT, you can observe she got a 4 mm forward growth of the maxilla, and also she got a 6 mm of the maxillary posterior dentoalveolar height development. And when we superimpose on the mandible, you can see there was an 8 mm contact growth at the right side and 10 mm contact growth at the left side. And this explains why the mandibular asymmetry and the occlusal cant were improved. And also she got a 3 mm lower dentoalveolar height development. So that's put everything together. Was she got a 9 mm of overall dentoalveolar height development, which was equal to the 9 mm contact growth. Therefore, her mandible was redirected to growth downward for 8 mm. So for the conclusion of my presentations, I would like to conclude that the orthodontic total arch extrusion was an effective adjunctive treatment for controlling mandibular growth direction after maxillary orthopedics in growing patients with class 3 malocclusion. And the second is the orthodontic total arch extrusion technique grew the mandible backward and downward and improved the skeleton facial convexity, while the overall, that means the maxillary plus the mandibular posterior dentoalveolar height development exceeded the contact growth. Thank you very much.